for everybody for joining us. We really appreciate you joining us this month. Um, we are going to get started with our Echo series. We're going to start with the introductions like we normally do. Then we have our didactic presentation with Doctors Margarita Berwick and Adetola Louis-Jacques. We'll have the questions and discussions after next session. Information, the post-echo survey, and then closing comments. So we have our subject matter experts. I'm going to go ahead and let the few of our experts that are here go ahead and introduce themselves. So Dr. Bretler, you're first on my list if you want to go ahead and introduce yourself first.
Sure. Good morning, good afternoon, everyone. Jeff Bretler, internist. I help direct the regional hypertension program in Southern California, Kaiser System, faculty at the medical school there, and a consultant for the Pan American Health Organization. Excited to hear this talk.
Thank you, Dr. Bretler. And then Dr. DePetty, I saw you joining us. If you'd like to go next.
Well, hi, Kathleen. My name's
Hi.
Don Petty. I'm an internist here at the University of South Carolina School of Medicine. I'm the Health Sciences Distinguished Professor and former Dean of our medical school. I'm a primary care internist, but did do fellowship training in hypertension vascular biology. So my area of interest is in hypertension and cardiovascular disease. And also, as Dr. Bretler, I'm a senior consultant to the Pan American Health Organization and the World Health Organization.
Thank you, Dr. DePetty. And then Emily, I saw you here.
Hello, and my name is Emily Ridley. I'm a clinical pharmacist based out of an internal medicine residency clinic within Prisma Health in Columbia, South Carolina. I serve primarily low-income urban population, but we've got a number of rural patients as well that we see. Work with our patients daily, helping a lot with hypertension and diabetes primarily, but worked with our health system across the state with quality improvement efforts regarding hypertension control. Looking forward to the talk today. Thank you.
Thank you, Emily. We do have 3 subject matter experts that are not able to attend today. Honey Estrada, who is with the North Carolina CHW organization. Dr. Daniel Lackland, he is an epidemiologist in South Carolina. And then Monty Robertson is with the Alliance out of South Carolina. And we just thank everybody for joining us. Sydney has put into the chat, if any of the participants could please go ahead and share your name, employer, organization, and position and credentials into the chat. That way we can get to know everybody more. So we're going to meet our presenters today. Our first presenter is Dr. Adetola Louis-Jacques. She is an assistant professor in the Department of Obstetrics and Gynecology at the University of Florida, where she contributes to the UF Health Maternal-Fetal Medicine program with a strong focus on breastfeeding medicine. Dr. Louis-Jacques earned her medical degree from the University of Vermont and completed her OB/GYN residency at Lehigh Valley Health Network, followed by a maternal-fetal medicine fellowship at USF. She's been recognized for her excellence in medical education, research, and patient care, including receiving the Society of Maternal-Fetal Medicine American Association of Obstetricians and Gynecological Foundation Scholar Award from 2017 to 2020. And then Dr. Margarita Berwick graduated from Wake Forest School of Medicine in North Carolina and completed her residency in obstetrics and gynecology at the University of Florida. Her passion for breastfeeding research began with her first child with the challenges she had. Since that time, she has pursued clinical training and research in the field of lactation medicine. Her breastfeeding clinical interests include patient and clinician education. Her research, sorry, her research interests include the intersection of lactation and medical conditions, breastfeeding, and disabilities. Dr. Berwick has co-authored several publications related to breastfeeding and dedicated time to educating trainees. And I will turn this over to Dr. Berwick and Dr. Louis-Jacques.
Good afternoon or good morning. It's a pleasure to be here. Thank you for the invitation. I hope you can hear me well. I'll be doing this with my lovely colleague, Dr. Berwick. I'll start the presentation and then transition to her. No disclosures at this time. Next slide. Our objectives are to review types and incidence of hypertensive disorders of pregnancy, to understand the short and long-term benefits of breastfeeding for individuals with hypertensive disorders of pregnancy and their offsprings, really more focused on the maternal for this presentation. And then evaluate impacts of hypertensive disorders of pregnancy on lactation and discuss they said someone mentioned slides are not visible. I can see them. I'm not sure if that's if everybody had the same issue. Okay. Okay. And we'll thank you.
Is
and
that better? Okay. Sorry about that, guys.
No worries. And then we'll talk about management of lactation and how to think about medication selection. Next slide, please. So for just hypertensive disorders of pregnancy in general, classified into three main areas: chronic hypertension, gestational hypertension, and preeclampsia, eclampsia spectrum. For chronic hypertension, this would be either they have a diagnosis before pregnancy or we started to notice blood pressures prior to 20 weeks. And then for gestational hypertension, blood pressures are noted after 20 weeks, and there's no evidence of any end organ damage, including protein in the urine or any symptoms or signs that shows worsening signs of preeclampsia. And then for preeclampsia, it's also similar, diagnosed after 20 weeks of gestation, but here we see proteinuria, we can see end organ damage, like kidney dysfunction, liver dysfunction, or severe range blood pressures above 160 or 110 we'll put in that category, even if there's no protein or no end organ damage. And then the extreme of the preeclampsia spectrum, other than other signs of end organ damage, is the eclampsia, where people develop seizures. This whole spectrum complicates about 8 to 10% of pregnancies in the United States, and the incidence is rising. Next slide, please. Would transition to discussing more about lactation and hypertension. Next slide, please. So there are many long-term benefits of breastfeeding, and this is an AHRQ report, very detailed review that came out in 2018, and one of the main findings was that lactation is associated with reduction in high blood pressure in people who breastfeed. Next slide, please. And then in the short term, studies evaluating blood pressure trends in the postpartum show lower blood pressures in individuals who breastfeed. Next slide, please. So this is a study by one of my wonderful mentors, Maureen Gore, who looked in the postpartum in the first 5 months, looking at the difference between people who breastfeed and people who formula feed only. And we can see that most are in the normotensive. This is a diastolic blood pressure here on the left, and the systolic blood pressure on the right. And we see the range is usually from 100 to about 115, but the overall, there's lower blood pressures in those who are breastfeeding, and this is significantly different with systolic blood pressures. Next slide, please. When we look specifically at not just people who are coming in with normal blood pressure, healthy postpartum individuals, and we look at both individuals who are normotensive currently, but also have preeclampsia or gestational hypertension, and looking at duration, the length of the duration of breastfeeding impact on blood pressures in the postpartum, we see significant differences in the group who have with gestational hypertension. You can see these numbers are small here, but that's the group that with noted differences in systolic blood pressure and diastolic blood pressure. Next slide. This study is specifically looking at patients with preeclampsia and looking at blood pressures in the postpartum, but also taking a note of looking at early preeclampsia versus late preeclampsia, which speaks to a little bit more of severity. And in this group, the breastfeeding, the desire to exclusively breastfeed was the same from early and late preeclampsia, but there was a higher group of people in with an intent to only formula feed in the early preeclampsia group. Also, the rates of breastfeeding at discharge was also lower in the early preeclampsia group. However, when we look at the postpartum visit and look at people who were lactating or not lactating at that postpartum visit, we see that there is a difference in blood pressures for the early, in general, in all the preeclampsia group, but when you break it down to early and late, there was difference in systolic, in the mean postpartum systolic blood pressure and diastolic blood pressure in the early onset preeclampsia group. Next slide, please. I think one of the main reasons, and just to pause here, is that we know that preeclampsia and gestational hypertension increases the risk for the birthing person long term, including kidney injury, chronic hypertension, cardiovascular disease risk, thromboembolic risk, and diabetes. And just because of the purpose of this discussion, we focus mainly on that chronic hypertension. And so if we know that the risk is higher to progression to chronic hypertension, and we have an intervention potentially to decrease that risk, is the purpose of thinking through how does lactation start to mitigate some of this long-term sequelae of hypertensive disorders of pregnancy. We could go to the next slide. And so this is just an example showing this protective effect, the 13% reduction in risk of hypertension with breastfeeding lifetime greater than 12 months. Next slide, please. And this is, we've talked about duration, we've spent some time in duration, but to also, this is one of our preliminary analyses using the child cohort in Canada, is that the dose, the intensity of lactation also matters. So here is looking, this is a combined composite risk of type 2 diabetes and hypertension with a comparison group of never breastfeeding. We see just, this is the one just before, to show that the beneficial effect, even just exclusive breastfeeding at 3 months alone, we see that there's a difference, where we've seen over 12 months of any breastfeeding from other studies, but exclusive breastfeeding at 3 months, you started to see a different more at 6 months, and with partial breastfeeding, we start to see maybe some of that benefit at a year of breastfeeding. So that duration matters. Any duration of more than 12 months lifetime matters, but even just exclusive breastfeeding of much shorter duration, you start to see benefits there. Next slide, please. Dr. Berwick?
Yep. Thank you, Dr. Louis-Jacques. I'll take it over from here. So as we discussed, although many studies do point to the association between increased breastfeeding, any breastfeeding, and improved cardiometabolic outcomes, the mediators of this effect have been more difficult to identify. It is important to note that a lot of the evidence has been derived from epidemiological studies. However, the studies have been large-scale, population-based, with consistent findings across different countries, and many studies do account for potential confounding variables. When we look at some of the potential mediators of lactation and improved cardiometabolic health outcomes, such as, again, reduction in hypertension, reduction in diabetes, and long-term potentially reduced risk of myocardial infarction and stroke and other cardiovascular adverse outcomes, some of those mediators are thought to potentially be social and behavioral in character. For example, women who receive stronger support and access to high-quality health care potentially can breastfeed longer and more intensively. People who receive stronger support in the workplace and have improved access to breastfeeding-friendly workspaces are likely to breastfeed longer. And some of these social impacts may account for the variation that then leads to improvements in maternal health long-term. There are emerging studies, however, that are evaluating the molecular mediators of this positive effect and the physiologic underpinnings of this improved cardiometabolic health long-term. One of those mediators may be the hormones involved in breastfeeding. For example, prolactin has been noted, which is increased during breastfeeding, and in those who breastfeed longer or for greater total duration would have longer cumulative exposure to prolactin, has been found to have a beneficial effect on vascular epithelium with reduced inflammation. Another question is whether it is breastfeeding in and of itself that leads to those improvements in maternal health, or is there potential, or is ability to breastfeed or breastfeed for longer potentially a marker of susceptibility to cardiometabolic illness? In multiple studies evaluating breastfeeding and improvements in maternal health long-term, increased adiposity and increased insulin resistance has been associated with both delayed lactogenesis, a need for supplementation, and non-exclusive breastfeeding. And thus the question becomes, is the capacity to breastfeed, or is the capacity to meet 100% of the newborn's nutritional needs with breast milk is a marker for susceptibility, or rather non-susceptibility, to cardiovascular, adverse cardiovascular outcomes long-term. Next slide, please. Notably, women with hypertensive disorders of pregnancy do appear to derive greater long-term cardiometabolic protection, especially when, as we noted, breastfeeding takes place for a longer duration of time. And the benefits that have been noted are sustained for as long as 18 years after breastfeeding exposure. I do want to note that in these studies, particularly the studies included in the meta-analysis, the outcome was assessed in majority of studies after age 40. It looked into ages 45 to 50 and some as late as 80 years of age. Next slide, please. We'll next transition to talking about hypertensive disorders of pregnancy and their effect on lactation. Next slide, please. Now, studies from the United States and abroad show that women with hypertensive disorders of pregnancy initiate breastfeeding at lower rates and also breastfeed for shorter duration compared with women without hypertensive disorders of pregnancy. Next slide, please. In a recent study that used one of the large nationally representative survey systems, pregnancy risk assessment and monitoring system, adjusted, the study accounts for almost 10 million US women. Again, the study confirmed that hypertensive disorders are associated with higher odds of never breastfeeding and then earlier cessation of breastfeeding in those with hypertensive disorders. Next slide, please. Now, when we look at the risk factors for disrupted lactation, number one is few studies have specifically looked at short-term reasons for decreased breastfeeding in women with hypertensive disorders. Two studies over the past 5 years did look at least self-reported reasons for why women did not initiate breastfeeding. Notably, one study from a Canadian cohort did report association with self-reported insufficient milk supply, and a study in the United States reported a similar finding, as well as noting that some moms reported being too sick to breastfeed or that their newborns were jaundiced. But if we look in general at some of the conditions that are more likely to occur in people with hypertensive disorders of pregnancy, those also are risk factors for disrupted lactation. Some of those include presence of medical comorbidities, particularly diabetes and obesity, chronic illnesses, prolonged hospitalizations or more intensive hospitalizations, cesarean delivery. In the neonate, prematurity and low birth weight, neonatal intensive care unit admission, complications, medical complications in the newborn. Separation from the infant is a known risk factor for disrupted lactation. It is more likely to occur in people with hypertensive disorders, whether it's due to maternal or child health reasons. And then lastly, there is a significant overlap between risk factors for hypertensive disorders and also non-initiation of breastfeeding. And a lot of these pertain to some demographic characteristics, such as being younger, being melliparous, meaning experiencing their first pregnancy and delivery, some health behaviors such as smoking. All of those are risk factors for decreased breastfeeding in general. If we could go to the next slide, please. Now, what can the healthcare provider and the healthcare system do to support individuals with hypertensive disorders of pregnancy? Now, in many people, now advanced planning is helpful. However, it's not always possible because the diagnosis may be sudden and hospitalization may be sudden. However, if possible, and perhaps if some of these services are accessible through the hospital, lactation consultation can be invaluable in helping patients understand the strategies that promote successful breastfeeding initiation and continuation of lactation. And colostrum harvesting. So colostrum harvesting refers to, I also love the word harvesting, by the way. Colostrum harvesting refers to collection of colostrum, which is the first milk produced in the breast prior to delivery. There are different techniques that are available to complete this. In some individuals, that may be pumping versus hand collection, and it has been noted to be a safe option for those without contractions, preterm labor, or fetal distress. And we can go on to the next slide. Now, it is important to note that lactogenesis or milk production typically begins as early as actually the second trimester of pregnancy. So as early as 16 to 20 weeks of pregnancy, colostrum can be expressed. Interestingly, this colostrum that's produced prior to the birth of the infant, it is nutritious, though some differences in nutritional composition have been found compared to colostrum that's produced after the birth. When could this be helpful? If there is a potential for, number one, delayed onset of large volume milk production, And we know that individuals with increased adiposity, individuals with diabetes and hypertension many times are at risk for delayed onset of large volume or copious milk production. It may be helpful if there's anticipation of separation of the mother and infant. For example, there's the prematurity and anticipated neonatal intensive care unit admission. And then also if the birthing parent is at risk for prolonged immediate post-surgical recovery. Go to the next slide. Now, other things that are helpful in helping patients with their decisions to breastfeed and supporting and encouraging their decisions to breastfeed. Ensuring access to a breast pump is an important practical point. A lot of clinicians that may be encountering these patients in the postpartum period may be clinicians in the emergency department. They may be clinicians on the internal medicine units. These patients may face the need to be transferred. So thinking about acquiring a breast pump or ordering a breast pump for the unit for the patient early on in the course of their presentation is important. Typically, especially in the early weeks after the birth of the infant, removing breast milk from the breast every 2 to 3 hours is going to be important, not only for providing nourishment to the infant, not only for maintaining lactation, but also for patient comfort. Breast engorgement can be very painful, uncomfortable, and potentially failure to remove the milk in a timely manner can lead to additional complications, including mastitis. Now, other considerations for patients that may be presenting in an acute condition, severely high blood pressure, potentially other conditions that place them at risk for potential intubation or sedation. It is worthwhile to discuss with the patient ahead of time whether or not they would like to continue lactating if they're critically ill and sedated, and obtain patients' permission ahead of time to remove the milk or pump the milk from their breast while they are not awake, such as under the effect of sedation. And next, please. Once a patient is stable, or if a patient is stable, again, to help them be successful at home, for example, prior to their delivery, hospitalization, discharge, or if they were hospitalized after the birth of the infant, it is important to talk about their options for having a breast pump at home. Thankfully, the process for people, at least with insurance, has been simplified. And I always give a practical tip that you can share with patients. One can Google breast pump order through insurance, and several services online can provide patients access to a selection of breast pumps available through their insurance carrier, as well as free options and options with a really low copay. And that's something that a patient can do from their cell phone in the hospital without the need for a healthcare provider to take any steps or give them an order for this. Next slide, please. Now, as we talk about medical aspects of management of hypertension, one of the questions related to lactation is, of course, pharmacologic treatment. Now, it is important to note that blood pressure medications are increasingly used for postpartum blood pressure management. It's also important to note that currently there's no single universally accepted target for when to initiate blood pressure medication with regard to systolic and diastolic blood pressure values, and also what values to use as our guides to considering our therapy a success. Now, if we look across different society guidelines, both in the US and abroad, for most guidelines, the recommended blood pressure range for initiation will be somewhere in the 140 to 150 millimeters mercury for systolic blood pressures and about 80 to 90 millimeters of mercury diastolic blood pressures. Now, whether or not to initiate treatment and at what threshold specifically for gestational hypertension or preeclampsia without severe features. Currently in the US, there's no clear guidelines on when such treatment may be appropriate. Lastly, if we think about whether there is impact from medications on lactation in terms of ability to lactate or duration of breastfeeding, one trial has addressed this question, and it's actually a large trial that assessed treatment of chronic mild hypertension with medications, and there were no differences in initiation of breastfeeding or duration specifically related to use of oral medications in that cohort. If we could go to the next slide, please. Now, let's briefly talk about general principles of using medications in people that are lactating. We'll focus, of course, on medications used to treat high blood pressure. Now, all medications and really further, just about any substance administered to a lactating person, sometimes even ingested by a breastfeeding person, will be excreted in breast milk to some extent. Now, the good news is medications used commonly for blood pressure management have great compatibility with breastfeeding. Now, general rules, I think one of the key variables for a clinician, especially clinicians that perhaps are not obstetricians, gynecologists, but key variables to consider and is readily reported is relative infant dose. Although relative infant dose does not tell the whole story about medication safety, but generally infant doses less than 10% are considered a safe threshold. It is also important to consider infant age and amount of breast milk received by the infant. So for infants greater than 6 months in, of course, observational and epidemiologic studies, and we're not talking about just blood pressure medicines, but medications as a whole, there have been few cases of adverse events reported, and particularly if we're talking about severe events such as hospitalizations, that may be related to, again, the amount of breast milk that infants are exposed to, which decreases at that time point in a lot of cases, but also the maturation of the infant's metabolism and just increase in infant's weight, which then decreases the relative exposure. If breastfeeding is not exclusive, meaning there's supplementation with formula, supplementation with solids, there's use of donor milk, of course, that proportionally decreases the amount of breast milk and any medications contained in the breast milk proportionally. And just to briefly note, other pharmacologic properties that are favorable in breastfeeding would be high protein binding, meaning there's less free drug available to cross into breast milk. High volume of distribution, again, when the substance is distributed across multiple body compartments, essentially we consider that fewer molecules would cross into breast milk. And then a short half-life, again, that is applicable to some degree with some of the blood pressure medications, but of course we do use a lot of sustained release medications, in which case half-life does not become a consideration. All right, next slide, please. So let's briefly talk about a case. And the patient we have here is 36 years old. She's a para 0212, so that means she's had 2 prior births, and both of them were preterm. And she also had 1 pregnancy loss or miscarriage. Her medical history is notable for type 1 diabetes, chronic kidney disease with baseline creatinine of 1.4, and also chronic hypertension. Her pre-pregnancy blood pressure regimen consisted of lisinopril and HCTZ, and with diagnosis of pregnancy, she switched to nifedipine 30 milligrams daily. It is gradually increased to 60 milligrams twice a day. Labetalol was later added and up-titrated to 600 milligrams 3 times a day. However, at 31 weeks and 2 days, she is diagnosed with preeclampsia with severe features and admitted to the hospital for standard management, which would include magnesium sulfate and blood pressure treatment. The next day, her blood pressures are persistently exceeding 170s to 180s, systolic over 110 diastolic. She develops a persistent headache and is thus urgently delivered by a repeat cesarean. Now, post-delivery, her labs are at baseline, but her blood pressures are persistently exceeding 150 systolics and 90s to 100 diastolic despite maximum doses of labetalol and nifedipine. The patient desires to exclusively breastfeed and is pumping for her infant in the NICU. So let's go through some decision-making points for selection of medications while breastfeeding. Now, if we talk about treatment of acute hypertension, medications that are used for acute blood pressure lowering include intravenous doses of labetalol and typically hydralazine, as well as oral nifedipine, that's immediate release, not an extended release formulation. Now, these medications are compatible with breastfeeding. They have favorable pharmacologic properties. They have a short duration of action, and a very little quantity is excreted into breast milk. Magnesium sulfate is one of the central tenets of treatment of hypertensive disorders of pregnancy. Again, it has been found to be compatible with breastfeeding. It has been used extensively in individuals, at late stages of pregnancy and early in the postpartum period with no unnoted adverse effects on the infant. Now, there are some rare cases, and we will use some additional considerations for those. So IV intravenous seizure medications or antihypertensive drips are used rarely, and we'll talk about how to guide decision-making for these unusual cases. And then in other unusual cases, intubation or sedation. Now, breast milk expression can be performed, just as breast milk can be expressed after general anesthesia or contrast administration. But of course, in patients that are sedated and cannot give consent, it is important to have knowledge of patient preferences, values, and desires before collecting breast milk in that situation. Next slide, please. Now, this is an algorithm that can be used for decision-making, not just for antihypertensive medications, but medications in general to be used during lactation. Now, of course, if a well-studied medications that are commonly used, that have been used for a long time in clinical practice with no safety concerns, if those medications can be used, that's the first choice, and those medications can be prescribed. Now, more often, though, medications may have an uncertain safety profile, or there may not be any safety information available. So some of the resources that clinicians can utilize for decision-making are, they're both online resources and call centers. For online resources that are free, some key resources to highlight would be Infant Risk Center. So this resource has an extensive collection of articles that cover both a huge range of medications and pharmaceuticals, also cover lifestyle topics, things like Botox, filler, cosmetic interventions, and medical procedures. Infant Risk Center also has a free call center for clinicians that operates between the hours of 8 a.m. and 5 p.m. LactMed is a popular resource. It is readily available and can be utilized. It is regularly updated. Some of the challenges sometimes of using this resource is it may not contain a clear recommendation because it presents data which many times may be limited, and it may use a lot of the pharmacologic variables for clinicians to make a decision regarding whether or not a medication can be safely used, and that's where it is helpful to understand some of the characteristics that are more helpful for breastfeeding or more compatible with breastfeeding. Academy of Breastfeeding Medicine has a number of practice guidelines as well that can be accessed for free. Now, for situations where safety medication or safety information is not available, again, considering a consultation with expert centers such as Infant Risk Center or Rochester University Center, they do have access points for clinicians with a phone number that can be used. And in some situations, a medication with uncertain safety profile or even potentially with previously reported adverse effects may be used. And in that case, it is important to alert the pediatrician to the use of this medication so that appropriate infant surveillance may be instituted. And some general strategies for optimizing safety can be used and are listed here for your reference. We can go to the next slide. Now, in terms of first-line medications that are used for blood pressure management, extended release nifedipine, known as Procardia, labetalol, and hydralazine have been used for a long period of time in both pregnancy and postpartum individuals. But the important thing to know is a variety of other medications have great compatibility with breastfeeding and can be used in patients that require these medications. And if we can go to the next slide. So if we refer back to the patient from our case who has type 1 diabetes, chronic hypertension, and had a pre-pregnancy regimen of lisinopril and HCTZ, if we then think, well, in the patient that's not requiring maximum doses of standard medications used in pregnancy and postpartum, what would be her options, and does she have other options? And really, if we look, a lot of these medications are listed as sort of second line because although they're efficacious, they're safe based on pharmacokinetics and dynamics, but they have limited experience in breastfeeding. However, medications like lisinopril and enalapril belong to the ACE inhibitor class and may be appropriate for a medication with this list of comorbidities, such as longstanding diabetes and chronic hypertension that pre-pregnancy was managed well with this medication. These patients are candidates to be transitioned to these medications, particularly if they're known to have worked well in the past. I did want to highlight two resources for clinicians. If questions arise, you don't have time to make a phone call or do an extensive search. Two recent articles that you can find in the left lower corner of the chart. One published in 2025, again, details, updates in hypertension management thresholds, various guidelines from different societies, medication choices that are safe and appropriate, and strategies for medication selection. And then a 2018 article by Dr. Anderson that again outlines different choices and what makes them more or less favorable. Right, if we can go to the next slide. Now, these are just two resources that can be shared with patients. For example, if the patient from our case calls back and she says that she looked on the internet and she saw that lisinopril is perhaps not compatible with breastfeeding, which I do want to say is common. Many medications will contain cautions online. There are many resources that still list them as being contraindicated. There are at times pharmacies that will advise patients not to breastfeed or to contact their clinicians. But these are two resources that are patient-friendly and patient-facing that can be shared. These are online resources for those patients that may want to do their own independent research from a reputable and up-to-date source. All right, we can go to the next slide. All right, questions?
Okay, we will open it up for questions and discussions. Thank you so much, Drs. Berwick and Drs. Louis-Jacques. It was a great presentation, so educational. We really appreciate it. Does anybody have any questions? Comments?
I can start. First of all, great talk, very informative, enjoyed it much. There's a kind of a significant information knowledge gap or loss when we transition from OB-GYN into primary care. So are there secrets, pearls, health system approaches for primary care to acquire this knowledge? Have you found anything that works in practice?
From a perspective of transition of care knowledge gaps with OB obstetric care.
Right. So we'll see these patients in primary care, but the importance of potentially now promoting breastfeeding in patients with hypertensive disorders of pregnancy, probably not well understood in primary care. What medications, I think primary care clinicians often throw their hands up and look at the references and see the warnings with everything. So I'm just curious if you found anything
Absolutely.
successful for that transition.
I think two things. One was um, we did as part of lactation education of taking time to teach about medications because if you look at just the resource itself, most will say do not use during pregnancy and lactation. So people are highly restricted of just sharing what resources are available to them, who to call if they go to the pharmacist and they don't give a certain medication they need. So education on that end. From provider education piece, I think a lot of what we've been engaging in, Dr. Berwick and I, is doing a lot from like publishing in cardiology journals or in primary care journals and really thinking through. I think a lot of people who have kind of grasp the adverse pregnancy outcome is a higher risk, but that's the knowledge that suboptimal lactation is a higher risk is not out there. And the combination of those two, and how do we really guide management and take care of people? I think we don't even have strong evidence of how do we approach that, how do we minimize that risk when there's suboptimal lactation and there's adverse pregnancy outcome. But really trying to prove that have that literature even be beyond obstetrics and prenatal journals to get it out to primary care and cardiology journals, and to have conversations in spaces like this have been really important. I don't think the onus should just be on the pregnant and postpartum patient, but how do we also get this information across? Dr. Berwick, thoughts?
I agree. I think our goal should be to overcome this prevailing message that medications are unsafe and that we have few options or no options. And as a matter of fact, it's become as simple for me as explicitly telling my patient that just about any medication I may prescribe, including something as commonly used as Flagyl, metronidazole, actually has warnings and is sometimes refused by pharmacy. And I think even just giving the patient that understanding that they may have that experience, so it helps remove at least one of the barriers. And then I agree, the overwhelming message again is that medications are unsafe, and educating our colleagues in other specialties, and honestly ourselves in our own specialty, and then also disseminating that information will be critical so that the message changes. And again, that's why I wanted to highlight resources like Infant Risk Center, Health Meds. Those are sources that have the more up-to-date approach and are accessible to both patients. They're both patient and clinician facing.
I think another critical kind of conversation is this: instead of the pump and dump, is a pump and save. Like, it's really distressing for people to pump and then just pour it out because of a lack of knowledge on the provider part. Is just to say, pump and save it. Let me find the right information for you. Don't throw it out yet, because there are many things. They could give that milk later when the baby's gut is much more developed. They can mix it with milk. They didn't have that medication. Even if there's concern, they could give it there's so many different ways around it. And what may come back is what you thought needed to be dumped most likely could have been saved and used. So that just provides a little room to say, let me find out this information, save it, and making sure they have a pump they can use, or they know how to hand express, and they have people who can help them transition back to feeding at the breast or chest if that's their desire.
Great, thank you.
This is Don DePetty again. Most of us are practicing in the Southeast, and similar to Florida, and Emily alluded to this, I practice with Emily here in Columbia, South Carolina. We have a very diverse population, race, ethnicity, socioeconomic, and cultural. As a primary care physician, what should I be aware of regarding important socioeconomic, cultural, et cetera, barriers, if you will, or even facilitators for breastfeeding?
I think that when we look at the literature, we know that age there's lower with lower age, lower breastfeeding rates. With race, the Black non-Hispanic people have the lowest rates of breastfeeding, but that there's such historical antecedents to that, and sometimes assumptions and access and places where people deliver, and so there's so many layers. But asking, I think number one thing is asking, supporting, promoting, protecting, and in that we can mitigate some of the disparities, because most people can achieve lactation, and most people can achieve lactation fully with adequate support. So I think knowing some of the structural, like even just where people work that Dr. Berwick had talked about, having workplace support and the legal bearings now that could help with that, that you are protected to have this much time and breaks to pump if you're away. Spaces in childcare, where if you're in communities with like childcare, they do not support um that do not support breastfeeding or treat breastfeeding like some like it's dirty, where we've done studies looking at childcare centers. So it's so many multi-level layer of who is there with this breastfeeding person from pregnancy all the way to 1 to 2 years postpartum. But there are very clearly that there's socioeconomic, racial, ethnic barriers to lactation and lower rates.
Thank you.
You're welcome.
I did want to add, I like to, of course, the disadvantage you have as a primary care provider is, you're seeing patients many times some weeks after they have delivered. And a lot of the decisions about breastfeeding or a lot of the, challenges and potentially premature weaning occurs before the patient might see you. But some of the ways that are framed these conversations, because on the flip side, we want to support, we want to promote, we don't want to alienate our patients and make them feel judged or unheard. So the way I've started to frame it is to say, hey, my goal is to support your goals, to help you in whatever decisions you make. So I asked them, hey, tell me about some of the how feeding's been going and what are the decisions you made and what has helped you make those decisions. And then I did start to incorporate because I think, many times breastfeeding versus and formula feeding has been framed as benefiting the infant, but actually knowing that there are significant benefits to the breastfeeding person itself, I think helps strengthen our counseling and helps it seem less focused on the infant, and also takes away some of this powerful sort of formula marketing to say, well, it's great for your infant. It has all these things that nourish your infant. Well, you say, well, it doesn't have anything, to nourish the breastfeeding person. So I think spreading this knowledge about the cardiovascular benefits of breastfeeding can potentially help us promote breastfeeding in a way that hopefully feels more supportive to patients and focused on them as opposed to the infant alone.
I completely agree. And I think even the breast cancer, the ovarian cancer risk, the reduction in that risk, and when you share that, I think it hits people differently because most of the message is infant focused. I think also taking time to say, most people do not meet their goals. So 70% of people have breastfeeding goals they do not achieve. It's not the forceful of, I want you to do this, but it's in knowing that even when people desire to do what they would like to do, they can't meet it for many, many factors. Some of them are including us and our advice. And so I think just the asking of a question of what are your goals? What are your infant feeding goals? And then figuring out how to help them. What are your concerns and the barriers you have? And then figuring out how to help meet those, I think. And then in a population and community level wise, knowing what those risk factors in from workplace and childcare and all of the things we could do to help people have a better space to breastfeed.
I just wanted to read, we have a few comments in chat. So Sydney said she's almost 6 months into her breastfeeding journey, and she's honestly been scared to even take a Tylenol sometimes. So she wanted to thank you for providing the resources about medications that can be safe for breastfeeding. And she thinks the patient-facing education is so very important to support and encourage the breastfeeding mothers. So she just wanted to say thank you very much for that.
Thank
Are
you,
there
Sydney.
any, we've just got a few more minutes. I was going to go ahead and close up unless there's any more questions or comments real fast. Okay. Well, we wanted to say thank you so much to Doctors Berwick and Dr. Louis-Jacques. We really appreciate this chat. It was just very educational. Thank you so very much for joining us today. Our next echo session is going to be Thursday, September 25th, and that will be presented by Valerie Perez, and she is talking to us about bridging the gap, managing hypertension and cardiovascular disease in the unhoused populations. And I think that's going to be really fun also. Well, I shouldn't say fun, but educational and a very interesting topic to talk about. So please join us for that. This is our team. So again, on behalf of our team, we appreciate you spending the hour with us. We love to get to meet everybody, and thank you so much. Our post-echo survey will pop up at the end when we close out. But if you don't have a minute to do that, there is our QR code. You can go ahead and scan that. And we thank you for joining us today. Thank you so much. And we hope that you guys have a great day and a great holiday weekend. Thank you so much, and you guys take care.